Great. So Joe, we've talked so far about the risk in patients. Let's talk about a little bit about the risk in physicians. I mean, our audience is out there writing opioids. Do you need to document, or how do you document, and how important is it to document your rationale for prescribing opioids?
I think it's a great point. I think first we have to understand some of the perceptions. And we have to realize that opiophobia may actually lead to undertreatment. Opiophobia on the part of the patient, I think we've sort of explained a little bit, but on the part of the prescriber as well. And one way to overcome opiophobia and to get appropriate opioid prescribing, I believe, is to do everything that we've mentioned thus far, but also have good documentation. I mean, if you're documenting and you're verifying that these patients are appropriate for this type of therapy, then I think you're going to be in a lot better position in the event you're ever called to question about your decision. And I think it's critically important that when we are monitoring our patients using an opioid risk management plan, that there's a comprehensive teaching element too. So it very commonly, once every quarter or so, I'll direct my patients to a website with the FDA or to maybe something at Johns Hopkins or one of the other universities that has validated information, vetted information, and tell them, you should go learn more about this. I also encourage them to get involved with appropriate advocacy and support groups. Let them get involved. If they own their pain, that's important, and I'll document that in my chart, just as much as I'll document whether or not they still should be on opioids. And I think we look at it, and wouldn't it be wonderful to say, well, you only use opioids when they're in severe pain. But the truth is, if we get them functional and we have them moving around again, do all of a sudden you start taking them off the opioids because you assume that, well, now we've reached that crescendo? It's like any other disease management. So I think we need to appropriately document, and I think we hope, like any other therapy, that eventually we can get the patient back to their normal baseline prior existing status. The truth is, when you look at patients going to chronic pain centers, these patients, have failed back surgery 3 times, they've tried stimulators, they've really tried everything. And there's not a lot of other options that you have except opioids. So you need to document that, and you need to have that clearly stated in your plan. Now, I really like what Chris said before about using the informed consent as a dynamic tool, as opposed to just a one-off. And going back and checking and saying, do you remember when we went over this document? That's a really nice idea, and I think it's something we should think about.
Yeah, I'm glad you brought